Hello and welcome everybody to the continuation of OCAL's COVID webinar series. My name is Patricia Phillips. I'm the Executive Director for the Central and Northwestern regions here at OCAL, and I'll be your moderator for today's session, COVID updates from the medical perspective. And today's speakers will be talking about the variants of concern, the vaccines, rapid testing, and some of their own lived experience during the COVID-19 pandemic. Introduce our first speaker, Dr. Leon Genesov. Dr. Genesov is a public health physician with York Region Public Health, and he joined York Region just recently, April 2020. He was previously the chief physician at the Ontario Ministry of Labour, and he retired from the Ministry of Labour in 2019 after 35 years. Dr. Genesov is a Royal College Specialist in Occupational Medicine, as well as a certified family physician. He's a recipient of Queen Elizabeth II Diamond Jubilee Medal, a recipient of the Ontario Volunteer Service Award, and a lecturer at the University of Toronto Faculty of Medicine. He graduated from the University of Toronto Faculty of Medicine, and he has completed certificates in management from both the Schulich School of Business and Queen's University School of Business.
Thank you very much, Patricia, and thank you to OCAL for the invitation to speak today. Thank you. So I'm going to be reviewing vaccines and a little bit about point of care testing, all in 20 minutes. So it's going to go pretty quick. And in terms of the vaccines, the situation in Ontario changes on a daily basis. So some of the information about Ontario here may be slightly out of date if you're listening to the media this morning, but we'll try and keep you as up to date as possible with it. Thank you. So again, we'll discuss the bit on the vaccines and point of care testing results and management. So I'm going to talk about York Region. By the way, I work in York Region, and so I'm going to be talking about vaccinations in York Region. So as of March the 16th, the total number of vaccines administered in York Region was about 93,000, almost 94,000. And in fact, as of last night, it was a bit over 100,000 vaccines administered in York Region. Total number of vaccines administered to people 80 and over, around 36,000, or that's increased. And the proportion of people over 80 who've been vaccinated, right now it's a bit over 71% as of last evening. And as you may have heard, we're going to start vaccinating people. Started yesterday. The people 75 and up can start booking appointments for their vaccination. So we're still in the phase 1 of Ontario's COVID-19 vaccination distribution plan, and the whole plan is on the Ontario government's website if you want to look at the phase 1, phase 2, phase 3, and I'll talk a little bit about that in a moment. So in York Region, we have multiple clinics in York Region. At Cortellucci Vaughan Hospital in the city of Vaughan, that's run by the hospital. At Cornell in Markham, Georgina Ice Palace, Maple Community Center in Vaughan, the Rain Twitty Complex in Newmarket, and the Richmond Green Sports Center in the city of Richmond Hill. And next week, we'll be opening up another community center in Markham. And Canada's Wonderland will probably open up around March 29th for a drive-through vaccine program. We had a pilot that ran yesterday, March 18th, and it was quite successful. A few bugs to work out for when we open the full drive-through program on March 29th or so, but it was a very successful program, so that was good. In York Region, we're continuing to implement a flexible hybrid model for vaccine distribution. So as you can see here, we've got multiple sites. Some are run by the York Region, and some are run by the hospitals in York Region. And we looked at different sites based on accessibility, population distribution, and neighborhoods of vulnerability. And as the vaccine supply increases, we can open up more clinics in York Region in the coming weeks. So the appointments of the vaccinations are all by appointment. They have to be booked online. People have to live or work in York Region to get the appointment. And you may have heard that for AstraZeneca, they're available in pharmacies in limited areas right now. And according to the news release from the province, it's going to increase in the number of pharmacies that are capable of delivering AstraZeneca vaccine. So not sure about the details yet, but watch for the news for that. Right now in York Region, we're receiving about 10,000 doses of vaccine per week, and we expect that to ramp up next week to about 60,000 doses a week that's being received. So what guides our mass immunization rollout? What kind of plan do we have? So it's based on the provincial distribution plan, as I mentioned, with phase 1, phase 2, phase 3, phase 1 with a limited number of doses available, phase 2 with the increasing stocks of vaccines available and expanding the population being vaccinated, and then phase 3, which will start in July, maybe earlier, but starting in July, opening up for anybody that wants to be immunized. In York Region, currently we're in phase 1, transitioning into phase 2. So we're currently vaccinating in York Region highest, very high, and high priority healthcare workers, residents that are over 75 years of age, and we're starting to schedule, as I mentioned, residents that are 75 to 79, scheduling them starting this week for vaccinations next week. And then the phase 2 populations in York Region will include people who live and work in high risk congregate living settings, frontline essential workers, individuals with chronic conditions, and their caregivers. I know we've been getting a lot of questions when they're going to start, so hopefully that'll be coming soon. And then other populations in the communities that are at greater risk. And then phase 3 is will be open to everybody that wants a vaccine, of course, pending the availability of the vaccine supply. So this is based on an ethical framework, and in the York Region, we put a lot of effort into developing a ethical framework and worked with the Ontario government, which released an ethical framework for COVID-19 vaccination distribution, which is developed in partnership with a COVID-19 vaccine distribution task force. The ethical framework guides vaccine prioritization and distribution across the province to ensure that decisions related to vaccine distribution priorities are consistent, fair, and transparent. And diverse perspectives are captured through this feedback and recommendations so that everybody who wants a vaccine is accounted for. So let me talk specifically about the York Region COVID-19 task force and what it's been doing in terms of vaccination. So the York Region task force ensures that our local approach in York Region reaches vulnerable groups as efficiently and quickly as possible. And it identifies how to serve priority populations within the province's 3-phased vaccine distribution plan, and it develops solutions for distributing and administering vaccine to various populations and settings, and provides education, outreach, and support. So this in York Region, the vaccine task force was established in January this year, and the group meets twice a week. And then the 2 working groups underneath it for the task force to support decision making on vaccine distribution and priority populations. So it's important. The vaccine task force has a very wide membership: public health, social services, fire, police services, Ontario health teams, primary care providers, family health teams, pharmacies, community health centers, the 3 hospitals in York Region, clinical ethicists, culturally aligned community organizations, interfaith communities, and Indigenous, Black, and other racially based communities and organizations are involved in the task force. I'm going to quickly talk about how vaccines work. This is a whole hour-and-a-half talk by itself, and I'll try and do it in 5 minutes or less, probably less than that, to discuss. But just a high-level overview of how they work. So both the Pfizer and Moderna vaccines are mRNA vaccines, and they give instructions to cells on how to make a specific spike protein found on the virus surface that the SARS-CoV-2 virus uses to enter cells. And this triggers the immune response. And then once triggered, our body then makes antibodies to the spike proteins. And these antibodies help fight the infection if the real virus does enter our body in the future. But once inside the cell, the mRNA rapidly dissolves by enzymes. It breaks down very quickly. It does not enter the cell nucleus, and it does not alter DNA in a cell. Now, mRNA is very unstable. So the vaccine places mRNA in a lipid bubble to make it into cells. And the lipid bubbles are very fragile, which is why the vaccine is stored at very cold temperatures and cannot be moved or shaken once it's completely thawed out. There are two viral vector vaccines approved in Canada, the AstraZeneca and the Janssen, and they work differently from the mRNA vaccines. So these viral vectors use a modified version of a different virus, the vector virus, to deliver important instructions to our cells. So these two, the AstraZeneca and Janssen vaccines, package DNA from an adenovirus together with some SARS-CoV DNA and encodes it for spike protein, puts it back into a shell virus cell, and inside our cells, once it's injected, the DNA encodes mRNA to make the spike protein, and then our body makes antibodies against the spike protein. And it typically, for all the vaccines, takes a few weeks after vaccination for the body to produce immunity. So the main idea for all the vaccines is how to produce something that looks like a spike protein and to get the body to provide an immune response and antibodies to the spike protein. It's not just the antibodies that respond. They're very important, of course, but it's other parts of the immune system that respond also. So let's just talk a little bit about the vaccines that are approved. As I mentioned, all the vaccines are effective at preventing COVID-19 infection, serious illness, hospitalization, and death. As you can see in the chart here, the Pfizer and Moderna vaccines are mRNA, and the AstraZeneca and Janssen are viral vector, approved in December, February, and March. Pfizer's for age 16 and up, based on the clinical studies that were done, and the other three are for 18 years of age and older. All are 2 doses except the Janssen, which is 1 dose, which will makes it a bit easier to administer, although it's approved, it's not available yet here. So every one of these vaccines helps develop immunity to the SARS-CoV virus. Each vaccine has been undergone a lot of clinical trials through the manufacturers, and of course reviewed and approved by Health Canada. At least for the AstraZeneca, for the Moderna Pfizer vaccine, it's approximately 95% effective beginning about 7 to 14 days after the second dose. So safety issues, as we mentioned, COVID-19 vaccines, safe, effective, approved by Health Canada, help protect ourselves, help protect others. By getting the vaccine, I encourage people to learn about the vaccines and be informed and get the vaccinations. Hospitals and deaths are reduced when you get vaccinated. If you want to look at a real life example, certainly in the UK, where they use AstraZeneca almost exclusively, the cases and number of fatalities have decreased unbelievably, just remarkably in the UK from using the AstraZeneca vaccine. So it's a good tool to get us back to normal, and we can see, at least in the UK and other jurisdictions, what the real world impact of vaccine is in helping us get back to normal. So some people will have no side effects from the vaccine. Many people will report mild side effects like sore arm and some other and potentially some people with fever and some other side effects. But the advantage in terms of preventing COVID-19 infection is huge. Right. So let me go on a little bit to point of care testing. Let's talk about that. So point of care testing is what used to be called rapid testing. And point of care testing refers to testing for COVID-19 in which the analysis is done at or near the point of specimen collection. And it has to be done using Health Canada approved test kits. So there's the three types of point of care testing. We've got antigen testing, molecular testing, and serology point of care testing. The antigen point of care testing is for screening purposes only. It's not a diagnostic or a confirmatory test. It's an additional screening tool. It does not replace public health measures such as screening, physical distancing, masking, hand hygiene. These all have to go on. It does not replace requirements to protect the health and safety of workers. So a lot of workplaces using antigen screening, but all the other measures have to be in place, even with antigen screening there. Physical distancing, masking, hand hygiene, screening on entry with the provincial screening forms, very important. And a preliminary positive test on antigen point of care testing should be considered a probable case of COVID-19. The specimens taken usually from the both nostrils or combined throat and swab from the nostrils. And as I mentioned, if the test is positive for antigen on antigen testing, the individual has to seek immediately a laboratory PCR test. So going to an assessment center and getting a traditional PCR test, preferably within 24 hours, to get a confirmatory test. And that's what's in the provincial guidelines. In the meantime, with the preliminary positive antigen test, the person has to self-isolate until the confirmatory lab PCR test results are known. And the results of preliminary antigen testing, if they're positive, has to be reported to the local public health unit in accordance with the Health Protection and Promotion Act. Molecular point of care testing, again, one has to use Health Canada approved molecular testing. So positive results here do not require confirmatory testing, and a positive result from a molecular test is sufficient for classifying a case as confirmed. However, a local public health unit might recommend further clinical or public health management depending on the situation. So a molecular point of care test can be used for diagnostic purposes or for screening purposes also. And the specimen here is an upper respiratory tract specimen, again, either a combined swab of the throat and both nostrils, or a deep nostril swab, or the front of both nostrils. There's a little flow chart for the rapid antigen testing, and the main ones are PanBio and BD Veritor is another one. So you can see here the path for what to do with the positive and negative test. Again, if it's negative, great. If it's positive, it requires confirmation on a PCR testing to see if it's really a true positive or a true negative with a antigen test. And here's the molecular testing with ID Now is the main one. Also, Gene Expert is available also, and it shows you here on the left symptomatic individuals without known contact with positive COVID-19 case, like school-aged children, the management there. In the middle, any individual that's symptomatic or asymptomatic with a known contact with a positive COVID-19 case, the management course there. If there's a positive result from the rapid antigen test, from the point of care test, and then on the right side, there's a flow chart here for asymptomatic individuals without known contact with a positive COVID-19 case. And then serology. So serology checks a serology point of care test, checks for COVID-19 antibodies, either IgM or IgG antibody, and it's only for use by trained health professionals. It requires a drop of blood taken from the fingertip with a lancet, and you get rapid results in 15 minutes. So a positive result in serology, however, does not need to be reported to or actioned by the public health unit, because it's not a screening test, it's not a diagnostic test, and on a day-to-day basis, the serology test doesn't really give us a lot of information. It's just that the person has antibodies and really doesn't tell us much else about their status. So a positive test does not have to be reported to a local public health unit. Briefly, just about variants of concern in York Region. I'll skip over this quickly because we're going to be hearing more about variants of concern. I'll just say that York Region posts information and data on its website about variants of concern. So you can go to york.ca/COVID-19 data, and we'll see information like this, charts like this about variants of concern. And same thing here on this page. In terms of variants of concern, where acquired and status of cases. There's also information, by the way, on vaccines and the vaccine data on the website at yorkregion.ca, as well as the information about signing up for the range of clinics on for COVID-19 vaccinations. Just to mention our expectations in York Region for organizational responsibilities, especially for people doing point of care testing or in general for workplaces in York Region. I want to emphasize that workplaces need to develop a COVID-19 workplace safety plan to minimize the risk of COVID-19 and to follow all public health guidance and Ministry of Labor guidance. Workplaces have to cooperate with the local public health unit in the event of a potential workplace exposure of COVID-19 or an outbreak investigation. And if they do develop point of care testing programs, they have to inform the local public health unit about the point of care testing program. And workplaces have to report all positive tests from point of care testing program to the local public health unit. And let's see, so there's our dashboard where we report all sorts of information there, the case counts and epi curves and vaccinations and trends and lab test results. Just in terms of reporting positive test results for workplaces, again, as a reminder, especially from my days from the Ministry of Labor, if there is a positive test, the workplace has to give written notice within 4 days to the Ministry of Labor, to the Workplace Joint Health and Safety Committee or Health and Safety Representative, and to the workplace trade union, if any, and also reports to the WSIB within 3 days of receiving notification of the illness. And again, just a reminder, you do not have to determine where a case was required. So if it's reported in a workplace, reported to an employer, the employer has to notify the Ministry of Labor about it. And so that's it for now. Thank you very much. And we're going to be taking questions at the end. Thank you. And
great. Thank you very much, Dr. Denisov. Lots of great information. And like you said, so much more. It could be an hour and a half of its own discussion, but do appreciate, thanks so much for the information. A lot of great information in there. Very, like you said, focused on York, but that is being spread across the province as well. We're following the vaccine, sorry, the rollout, the vaccine rollout, yeah, across the province that way. So keep an eye.
It's very exciting.
Yeah, as Dr. Denisov was saying, in your region to see what's available for you now. So thank you very much. I appreciate that. And we will take questions at the end. And again, if you do have questions, please put them in the chat and just include who it is you'd like to direct that question towards. And that'd be great. Thank you. All right, thank you. So next up, we have Fatima Tokmafshan. She is a geneticist and bioethicist at the Research Institute of McGill University Health Center. Her research focuses on rare genetic diseases. Fatima is a science communicator for COVID-19 Resources Canada, a pan-Canadian organization made up of multidisciplinary experts facilitating Canada's response to the pandemic. As a bioethicist, she reviews ethical and scientific soundness of research protocols and clinical trials, and has been carefully monitoring the development of vaccines and therapeutics for COVID-19. So thank you very much, Fatima. We'll turn it over to you.
Well, thank you very much to you guys for inviting me. It's a great honor and privilege to be here. I love science communication. I love talking about science. So some of the stuff I'm going to talk to you about, you heard the previous presenter go over. So I won't dwell on them for too long, but what I usually do is I try to use relatable, accessible examples, everyday examples, to make the science a little more accessible for everybody. Before I start, I want to say, si vous avez des questions en français aussi, vous les posez. Okay, so to better understand the current situation and that we are in terms of vaccines efficacy, in terms of variants, I think it's good to take a step back and do a little bit of a review of what we call molecular biology, but not everybody has taken molecular biology. So every living organism has some sort of genetic material. For us humans, we have DNA, which is synonymous to a recipe, if you will, which then gets transcribed, copied into an mRNA, which is synonymous to the copy of the recipe, the original recipe book that we were talking about. And then it gets translated to an amino acid, which is synonymous to this delicious, beautiful cake that you are seeing. So when we were talking about mRNA vaccines and the virus being an RNA virus, this is the stage that we are talking about. As I was saying, this is a very simple schematic of the virus. I've circled here, so the genes that basically code the spike protein, a very famous spike protein that you're seeing a lot of variations being introduced to, that you're seeing being the targets of vaccines and therapeutics, are basically synonymous to that cookie, that cherry that you put on top of your slice of cake. You could change, mutations could change, for instance, one or two ingredients. Instead of this being chocolate, you could end up with vanilla, you could end up with a strawberry flavor. Some of those changes and mutations, they don't really mean much in terms of the cakeness of the cake, but some of them, they can drastically and dramatically change the flavor, the shape, and basically the entire experience of it once the cake enters your body. And this is the case for the virus. This is a schematic of, again, the SARS-CoV-2, and identifying basically the mutations for the UK variant, the B117 variant. And as you can see, the spike region is where a lot of this is concentrated at. Because of the fact that these changes happen, they are a normal process of a virus basically going through its life cycle. It's constantly copying its genome, the RNA, and producing the final product that is the cake. It's important for us to monitor and study really well what those changes mean. And we've been actually doing this as part of Genome Canada, the federal government's entity called Genome Canada, which is funded by, partly by CIHR. We have been actually monitoring viral evolutions since April of last year. So since before the UK variant became infamous, the Brazilian variant, the South African variant, we've been actually monitoring the evolution of the virus in various regions. We have lineages scattered and evolving in your own communities in Ontario, in different parts of Ontario, in Quebec, in Alberta, and all around the country. We have our own Canadian lineages, which we're monitoring. So far, none of them have basically turned out to be of interest. So that's why our main one of our focuses is basically monitoring these variants of concern. The overall workflow for how we sequence samples and what happens once the sample is given to us from a public health lab is basically you go, you do your swab. What we do is we do a test. It's called a PCR test, and what that PCR test does, it basically looks for presence or absence of a single mutation, a single change in that recipe that is common between the three variants of concern. And if that answer is yes, if that particular sample has that mutation, then we know that that sample is basically could have one of the three variants of concern. So then it goes to a different lab that does the sequencing. We put it in this beautiful big machines. We read the entire alphabet of the recipe to figure out whether it's the UK variant, the Brazilian variant, or the South African variant. And using that data, we can create this kind of like family tree for the various lineages. These are the lineages that we currently have in Canada monitoring. So you can create a family tree of the different lineages, variants that are circulating in the country in a particular region, and monitor their change, monitor how abundant they become, and basically their epidemiology. Now, I'm not going to dwell too much on this because it was already reviewed about how vaccines work. our body, the immune system is a really fascinating machine when it comes to immunology. Immunology is one of the most complex, your immune system is one of the most complex and fascinating pathways in your body. It's controlled by so many different factors, a lot of it genetic, some of it environmental. So the cells in your body, just as you're sitting there, they're randomly creating a bunch of antibodies against things, some of which you have never even come in contact with. What happens is that these antibodies that are floating in your system, when they come across a new pathogen that they haven't recognized before, they pass the message along, and a whole other cascade is triggered, and you are experiencing an inflammatory response. With the vaccines, what we're doing, we're giving you just a tiny little part of the pathogen instead of triggering the whole entire cascade. You are basically just training your immune system as to what different parts of the pathogen looks like in order for your body to be able to fight it. Putting these two topics together in terms of the changes in the virus and the vaccines, the little pieces that we are introducing to your body in order for your immune system to recognize and be able to mount an immune response. So far, all the emerging data shows that the approved vaccines, and I don't have AstraZeneca here, but AstraZeneca as well, they are efficacious when it comes to B117, which is the UK variant. All the vaccines so far show a reduced efficacy against the South African variant, and also partial reduced efficacy when it comes to the Brazilian variant, P1. Now, this is only part of the picture, though, because your body it creates very diverse types of cell that recognize very different and small bits and pieces of the viral particle that is introducing your body through the vaccine. The tests that we run in the labs, they don't fully capture the diversity that we see in a human body. At the same time, the other aspect of it is we also haven't really been measuring the T cell, the very famous T cell response that your body can mount. So there could be scenarios where you're not producing enough antibody levels to be protected against a particular strain or variant, but your T cells will come in and basically give you enough protection. And also the fact that we have mRNA technology. With the mRNA technology, it will be very easy to very quickly adapt the vaccines for variants, and indeed that's what's been happening. Moderna and Pfizer are working on testing new iterations of their vaccines. When we talk about vaccines, their equitable and ethical distribution is very, very important. I was part of the advisory committee the federal advisory committee that basically put down recommendation as to what should be the main priority groups. And back of mind for us was constantly the issue of equity and how we can make sure we are protecting those that are most vulnerable and most at risk. So, but nothing is perfect. We are all human. We can things fall through the cracks. We have the biggest challenge we're facing right now is the supply chain issue, which we are expecting to be fixed in the near future. The other aspect of ethical and equitable distribution of vaccines is the issue of vaccine passports. That's a hot topic issue. We are actively discussing it, and it's a complex issue. It doesn't have a simple yes or no answer. There are instances where we will see private companies instituting their own regulations in terms of requiring either their employees or people who want to do business with them to show that they are immune, that they are protected. Whether it's something that should be implemented on a governmental level is a whole other issue, because again, you have to think about the entire population. You have to think about the single mother who is immunocompromised and can get vaccinated. How do you put in place rules and regulations that protect everybody, that you're not creating with that password, you're not essentially creating different classes of people with different privileges and further deepening the divide and the disparity that exists within our health systems. And for this last bit of my talk, I want to dispel 3 very common misinformation that we deal with on a daily basis. I do a lot of vaccine advocacy. The first and most frequent question I get all the time is, the vaccines were developed too fast. How do we know that they're safe? And again, as a bioethicist, I review regulatory data all the time. So this is sort of, I've been watching this from the start, and I've also have experience working on an mRNA vaccine for cancers. So I can tell you a lot of what has gone into particularly mRNA vaccine development and for other types of vaccines as well is previous knowledge. For mRNA vaccines, we had over 20 years of research that built the foundation as to what those nanoparticles are going to look like, how are we going to package it. The second most important contributing factor has been massive financial investment. Like the example of the US, they had the Operation Warp Speed, where the government just funneled a lot of money into development of Moderna vaccine, for instance. And then the unprecedented global collaboration. You hear the clinical trials for vaccines happening all around the world. This would not have been possible. I can't find that many clinical trials in the past that have been so well coordinated, so fast, and multi-centers across the globe. You have different regulatory jurisdictions across the globe. You have different populations across the globe. So that alone, that's huge and unprecedented, and it removed a huge impediment in terms of getting the numbers. Another contributing factor was cutting through the red tape. We usually submitting and then waiting for the regulatory bodies to review. You would see that Moderna, Pfizer, AstraZeneca, they would submit to a regulatory agency, and people were up literally 24 hours going through the data because there's a sense of urgency to it. And of course, in terms of how the trials were designed, as you can see in the schematic here, the way they were set up was to be sort of semi-parallel, and the data was being submitted as it was coming instead of waiting and doing like a submission once the study is done. They were sending it to their blinded data safety monitoring board as it was coming. So all of that together really helped to make sure that we have a vaccine in less than a year. It's not because any regulatory or safety corners were cut. The other very common question and misconception is whether the mRNA vaccines will be able to change your DNA. And the analogy I use here is it's just like how your food order can go back and change the menu from which you've ordered the food. mRNA has absolutely no way of going back into your nucleus where your DNA is stored and making changes. Believe me, in the lab, we try very hard to put RNA back into the nucleus of cell and make changes to the DNA. It's just not possible. It doesn't work. And lastly, in terms of vaccines and fertility, this is yet another very important issue, and it touches on equity as well. This misinformation started spreading because a big and powerful anti-vaccine group put out a misinformation saying that a protein called syncytin-1, which is an important protein for proper functioning of placenta, is similar to COVID-19 spike protein, and therefore the vaccine that you're going to get is going to basically damage that protein, and you're going to end up with having difficult pregnancy or affect your fertility. So that is absolutely 100% false. That particular protein, syncytin, has only a few amino acids, a few building blocks in common with the spike protein, as does any other protein in your body, because the building blocks for proteins are the same. So there's absolutely no scientific evidence to back this up. However, there is evidence that pregnant women are at a higher risk for severe illness. But having said that, vaccination is a choice. So the choice is the woman's. She should be making the decision, an informed decision in consultation with their healthcare provider as to whether get vaccinated or not. The Society of Obstetricians and Gynecologists of Canada has put out a statement saying that women who are pregnant and breastfeeding should be offered vaccination unless they have an underlying health condition that would preclude them from getting vaccines. And with that, I'll stop here and await your questions. Thank you.
That's fantastic. Thank you, Fatima. A lot of great information in there. So much science, and bringing it down to really understanding how it all works. So that was fantastic. Thank you so much. All right. And next up, we have Dr. Obed Adarkwa. And Dr. Obed was raised in Canada. And after completing high school at Marion Academy in Rexdale, Ontario, he accepted a track and field scholarship to the Northern University of Arizona. During his undergrad, he volunteered at Flagstaff Medical Center and also had an opportunity to participate in undergraduate research. After completing a bachelor's in microbiology with a minor in chemistry, he pursued a master's degree in molecular biology with the emphasis in cancer genetics. He enrolled at the Medical University of the Americas in January of 2011, where he completed his doctorate in medicine. While at university, he served as vice president of the student council body and was a teaching assistant for histology as well as microbiology and immunology. After completing his clinical rotations in Canada at the University of Toronto, McMaster University, Queen's University, and the University of Manitoba, and in the United States in May of 2015, he began his residency in internal medicine at an affiliated institution with the New York Medical College called Wyckoff Heights Medical Center in Brooklyn, New York. During his residency, he served on multiple committees, including the Graduate Medical Education Committee, the Critical Care Committee, and the Central Line Associated Infections Committee. Part of his responsibilities, in addition to patient care, included education of the medical students. He's published several papers and presented at multiple conferences during his time as a resident and a fellow, and is now in the process of completing his subspecialty and fellowship training in pulmonary diseases and critical care medicine. His experience with COVID-19 began very early in the pandemic before it spread throughout the United States. So with that, I will turn it over to you, Dr. Adarkwa.
Hello, everyone. And I want to say thank you again for giving me the opportunity to share my experience during this pandemic. So before we start, I don't know if you guys are aware of who this gentleman is. His name is Dr. Wang Liang, and he was actually one of the earlier physicians. He is the earliest physician, an ophthalmologist by trade, who discovered or started describing, I should say, the presentation of some of these patients that had COVID-19. He saw this, actually documented this, and spread the word to other colleagues, and ultimately got up to the world. Had it not been for him, we would have been totally blindsided. I mean, I don't think we were adequately prepared, but we were a little bit more prepared than initially. So we owe him a debt of gratitude. So what was the concern with this COVID virus? The thing is, it's not that we didn't know exactly what this virus is, because there were previously viruses that were in the family, so family of coronavirus, SARS that caused the what's it called, the infect that caused SARS, the virus that caused SARS back in the early 2000s, was in the same family as the SARS-CoV-19. So earlier on, we were a little concerned. How do we diagnose patients that had this disease? Before the advent of these rapid testing or the antigen testing that we have, that we can get within minutes now, before we relied heavily on PCR testing. And not all institutions or hospitals actually had these capabilities. So we actually had to send some of these tests up and waited days before we can even figure out if certain patients had these diseases, this disease or not. And so this was some of the concerns and some of the issues that we were dealing with. Also, earlier on, COVID hit during flu season. Did that mean that every patient that came in with those symptoms had COVID, or did they have the flu? Initially, some of these, the literature said that you either had COVID or you had the flu, and you couldn't. But guess what? In our very own ICUs, in our very own units, we had patients that initially we diagnosed as COVID, but then also found that they also had influenza as well. And there's always something you can do in terms of flu. If they're patient that's sick, there's certain things you can do to suppress the viral load. And we also had an issue, or not issue, but there was also concern in terms of who needed to be admitted to the hospital. Just because you had COVID, did that mean that everyone that had COVID needed to be admitted to the hospital? The truth of the matter is, the majority of people that did get COVID didn't require hospitalization. But those who required hospitalizations were the ones that we were concerned about, because there were one or two ways that they would turn out. Either they had a prolonged course and ultimately recovered and went home, or they had detrimental and progressively declined and required ICU, and ultimately, it wasn't a favorable outcome. So there was this concern, and we needed to make sure that whoever was positive knew they were positive so they can quarantine and decrease the risk of spreading this disease. Most of the patients that had these symptoms, the common presentation of most patients, like I said, didn't require to be in a hospital, but even fever was one of the main presentations of this infection, including symptoms such as a regular flu, myalgias, body ache, a dry cough. And these are even ways that my own parents who got COVID actually presented with. My colleagues and myself, who at some point we believe also got COVID, I was never positive for COVID, but my colleagues who had the same symptoms were positive for this. We had a lot of headaches and retroorbital eye pain, as well as the fevers and the myalgias. So this was very concerning, as I mentioned earlier, and we noted that some patients were hypoxic, but not the patients that required a hospital were not as severely hypoxic as the patients in the hospital. So what was the concern for frontline workers, further concerns? Well, we noticed that once these patients were in the hospital, a significant amount of them, during the pandemic here in New York, whole hospitals were pretty much converted to COVID units, pretty much, right? Almost very few floors actually had patients that did not have COVID. So if you've ever been in a hospital or ever treated a patient that had tuberculosis, that's an airborne disease. And normally we put those patients in negative pressure rooms. So what's a negative pressure room? Negative pressure rooms are these rooms that allow air to come in, but don't allow any air or circulating air within the room to spread out into the surrounding areas, thereby decreasing the probability of those particles, getting to the surroundings, right? But not all hospitals or not all rooms have negative pressure, are negatively pressurized, right, within the whole hospital, only a tiny few. This led to, some concerns that we had. Some patients ended up having the cohort as well. And these are some of the issues that, unfortunately, we had to deal with. How do we protect our families? I know a lot of us, in addition to changing our scrubs at the hospital, when we got home, stripped down and actually switched our clothes prior to getting even in the house. Some of my friends and some of my colleagues actually even stayed in their garages or actually paid for hotels to to mitigate the possibility of spreading an infection to their families, because we just didn't know. How do you know if it's not in your clothes, right? And then there was this whole issue, and I'm sure you saw the news on personal protective equipment, or PPE. We had issues of masks, gloves, gowns, the things that we almost in a way take for granted in terms of our day-to-day interaction with patients. This, because of such a massive influx of patients and the resources that were being utilized, limited the amount of supplies that we had, and got to the point where sometimes you will wonder, is it safe to reuse some of our gowns? Because what we would do is we go from one room with the gown and literally use like Clorox wipes or bleach wipes to wipe down these gowns because we didn't have any more, and then go into the next patient with COVID to go treat that patient, right? So as you can, as I'm speaking, I'm sure you can get an idea of some of the concerns that we had or some of the adversity that we face. But as an intensivist, how did these patients present to me? I mean, this virus, I have to say, was almost sort of like the gift that kept on giving. But it wasn't a gift. It was just, you name it, any presentation, you had these patients presenting. We had patients that presented with strokes, seizures, some of them so delirious because of the hypoxemia or the low oxygen in their blood. Some of them developed encephalopathy. They were completely unaware and out, right? A lot of them developed heart attacks, arrhythmias, like a colleague of ours. He actually got COVID. Prior to COVID, he didn't have any issues with his heart, but after COVID, developed arrhythmias. His heart rate would speed up to as high as 190, and normal is less than 90. So we just don't know the lasting effects of some of these diseases. And ultimately, some of these patients also develop cardiomyopathy, which is a fancy way of saying heart failure, right? A lot of patients also had diarrhea as their initial presentation, but interestingly, I remember this one patient we had who had been initially admitted for what we call Guillain-Barré syndrome. It's a neurological condition, usually as a result of exposure to either bacteria or a virus or something. And this patient was in our hospital, ultimately further decompensated, requiring the ICU. She was intubated, sedated, and we monitor in the ICU, we monitor your levels or labs quite often. And we noticed that there was a rise in certain parts of our lab parameters. As a result, we realized that there was something going on. So what did we do? We did a CAT scan. We did a CAT scan. What did we find out? We found that there was air in her abdomen. She had perforated her abdomen. How did this happen? We're not sure. We took the patient to the OR, right? They did surgery, and at the site, they actually swabbed the site of the perforation in the gut, right? And what did it grow? It grew, it did not grow, but what did the lab findings show us? The patient had COVID at the site, right? And oddly enough, 2 months after that, it was actually described by another health facility in our, our day-to-day journal articles that COVID actually caused this, right? Almost all our patients also that were in the ICU because of COVID also developed renal failure. Why the concern for this? Because if your kidneys don't work, you have difficulty with monitoring or actually dealing with acid base in your body. And these patients relied on the ventilator to help them because now their lungs are not working and then their kidneys were not also working as well. It caused issues with their endocrine function. They got superimposed infections and their inflammatory markers were through the roof. Now I left pneumonia here towards the end because that was most of the patients that came to the ICU. So most of these patients did have COVID pneumonia. On top of that, they developed superimposed infections. But interestingly, the very young patients, I remember during the 2-week spread, I admitted at least 3 or 4 patients that were in their 20s, and their presentation of COVID was being short of breath, hypoxia, but it was mainly as a result of massive pulmonary emboli, right? And this is when you have such a huge clot burden in that starts somewhere in the leg and then goes into the lung, that restricts or prevents you from getting adequate oxygen into your bloodstream, right? And if it's big enough, it can actually cause a strain in your heart and you could die. And so this was how some of these patients were presenting. Some of these patients also had respiratory failure ultimately and required being intubated or required going to the ICU. Now, why did they have this? They had something called ARDS. Now, if they see this, this is a CAT scan of most patients. Actually, not normal CAT scan, but I want you to focus on this. You have these are two lungs, right? This is your right side, your left side, and this is the heart with some blood vessels and some of the chambers. Ideally, you have your windpipe here, and it divides into two different windpipes, I guess I should say, that separate, or bronchi, that separate into the lungs themselves to help you get oxygen. Normally, it should be black, but you can see here, we see all this gray stuff here, and that gray stuff sometimes could be either fluid, it could be blood, it could be pus, but it's not normal, right? These are the picture of a CAT scan that we normally see in patients that have ARDS, but this was also what we saw in patients with COVID pneumonia. So what happens? Ideally, you get some type of injury, whether it's an infection or an inhalation or something, and that causes inflammation to these little air sacs in your lungs. That causes inflammation. So you get cells come there, they get leaky, and you get all this fluid that builds up in there, whether it's pus or just protein. And that makes it harder for you to have gas exchange, meaning oxygen coming into your lungs makes it harder for you to get oxygen to your bloodstream that you can then spread to your body, right? When your body tries to then heal itself through this process, what happens is it sometimes lays down new cells, some of this fluid gets reabsorbed, you lay down some collagen, and in a perfect world, this gets recovered, you recover, and the lungs go back to somewhat of its normalcy. But when you have such an aggressive process, you get these laying down of collagen, and this process keeps going, and you get what we call fibrosis or scarring. That makes it very, very hard for you to get oxygen now into these bloodstreams to supply your body, and that also affects your lungs' elasticity to take in air and also breathe. So these were something that was not good and a poor prognostic factor. I bring this up because the COVID patients, like I said, had lungs like this, right? And normally when we see patients that have lungs like this and we put a pulse ox, the oxygen level is extremely low. They're extremely hypoxic. Normally you see patients as an intensive, I see somebody with oxygen levels as low as in the low 80s or even high 70s. I'm saying we need to intubate that person right away. And when you intubate somebody, essentially what you're doing, you're giving them an artificial lung, right? And what it does is this, we put a tube down into your breathing hole, into your lungs, and this pushes air into the lungs and then allows you to passively breathe out, and it takes that air out, right? And so it's a way to try to help you ventilate and kind of unload the heart. So this is not what we saw though in some of these patients, right? Being that hypoxic. We realized that although they were hypoxic, they were able to tolerate this level of hypoxia, right? But just because you could tolerate it is not a good thing, right? So normally what we do is we try to augment or help these patients with their oxygen levels without intubating them. Some of these were modalities called high flow nasal cannula or non-invasive positive pressure, essentially to mask that blows air into your face to try to open up the lungs and try to help you breathe. And there was also steroids that we thought could be helpful. But earlier on, they said, no, you can't use any of this, which brings me to an interesting case because earlier on, I had also another young patient, a 28-year-old that was admitted into our ICU, because of COVID. But this patient was a little different. She also had asthma as well. We got to a point where I noticed she was severely hypoxic, went to assess the patient, and I realized she was wheezing. Now, if you know anybody that has asthma, you know that they take some of these puffers and they also utilize steroids when they're having an attack. But now we had this predicament. Do I give steroids? Why not give steroids, right? If I give steroids, they said that it could be harmful, but I need to give the steroids in order for this patient to help them, right? We gave the steroid, and guess what? They did actually better in the long run, right? And guess what? Literally weeks after within a month, there was literature out there saying steroids was something that was beneficial. And you can see here we have all these different treatment regimens that are out there right now. But as an intensivist working in ICU, honestly, the one that we see helping the most is the glucocorticoids, the steroids that are helping the most. All these out there, I think the verdict is still out on them. Some of them worked a bit. Some of them, I don't really see benefit from them, but we'll see. So when all else fails, what do? We intubate these patients, right? We intubate them. Why the hesitation? Patients don't do well when they get intubated. Earlier on, I think the survival rate for patients that got intubated, if they were above 65, were, I think, something like 3%, right? Which is abysmal, which is saddening, right? There's nothing much we can do for these patients. For some reason, you had no choice and you had to intubate it, because if you don't intubate them, they would succumb because of their difficulty breathing, because of the level of how low their oxygen is. But we only got a little bit benefit, right? And when we put these patients on the ventilator, for some reason, we needed more pressure to help them oxygenate. And because of their lungs, because of all that scarring that happened, it made it so much harder to help them breathe because their lungs were so stiff. This led to other complications such as hemodynamics. Their blood pressure would be low because of all that pressure. Their lungs would collapse and require chest tubes to take out some of that air out of their lungs in that chest cavity, so that didn't itself also contribute to them succumbing to the disease. They develop super infections called ventilator-associated pneumonias. And if you're on a ventilator and if you're not using a certain muscle, guess what? Those muscles atrophy. So guess what? You become even more dependent on the ventilator. So this vicious cycle, more pressure to oxygenate, that pressure causes injury, that causes inflammation, that causes scarring later on. Ultimately, this cycle, and you're almost dependent on this. So it's been almost a year, and as I reflect back on this disease and this pandemic, it took a toll on me and a bunch of healthcare professionals, as well as just the general public. But in healthcare, we saw countless number of patients dying. I mean, in the news, I'm pretty sure you guys saw certain hospitals here in New York having these trailers outside filled with bodies. Why? There was nothing we can do. They were in the hospital, they're in the ICUs, you're giving them everything you possibly could, but there's nothing you can do. And it was just you almost felt helpless, right? A lot of us had difficulty sleeping, having nightmares. And the issues got so bad, and the concern for COVID, that patients were actually saying, I'm not going to the hospital. If something's happened to me, all right, I think I better take my chances at home, right? As a result, people were even dying at home before getting to the hospital because of this, right? It led to a lot of anxiety, a lot of depression, a lot of PTSD. My wife was here, she'll tell you, I didn't even want to watch the news because sometimes I'd get some sort of feeling, anxiety or PTSD, what you might call it, just watching the news because of what it did to us, right? We're still in the pandemic, but it's a lot better than it was before, because in a year we've learned so much. We learned from our mistakes, we learned from the literature out there, and there's more for us to do, but I don't think we are out the woods. I mean, with the advent of these vaccines, I think we're getting in a better position, and I think what we need to do is get vaccinated, but even with vaccination and with these new variants out there, still got to be a little cautious out there. But with that said, I want to say thank you for giving me the opportunity to share my experiences. And if you have any other questions, feel free to ask me.
Thank you very much. A lot of powerful information there. Being right at the beginning and being in New York, I can only imagine some of the stories and things that you and your coworkers and colleagues have seen. And we know, as you said there at the end, the impact from a mental health perspective has just been astounding to healthcare, to many different industries, but certainly in healthcare for sure, the things that you've seen. So thank you for sharing. We absolutely appreciate hearing your experiences as a worker, and right in the heart and depth of it all. So thank you very much.
Thank you.
And I just want to take just a minute here to say thank you very much to all of our speakers, Dr. Genesev, Fatima, Dr. Adarkwa, for spending your time with us here today and providing some very timely information on these really important topics that are just, mentioned a couple of times. These things are all in the news and we're hearing about all these different, kind of information from different places and what do we believe and what don't we. So thank you very much to all of you for coming today and presenting. We totally appreciate your time. And a special thank you to Dr. Praveshta Nandan, who helped bring us all together and get this up and rolling for this week. So appreciate it, everybody. Thank you.
Okay, thank you. I had Jen just email me the chat list. So from Sammy Tardif, she's asking Dr. Genesov, who can administer the POCT? Can it be done by a layman or must it be administered by a healthcare professional?
The province changed the regulations for who can administer the testing. So it's somebody who's can it's not required to be a licensed health professional. And so anybody that's trained to do the testing can do it. One really needs to follow the manufacturer's instructions and be appropriately trained to properly administer the test. Right. So there may be just some other specific requirements for specific situations, workplaces, settings, but generally the provinces loosen the restrictions on who can perform the test.
If I could just add one more thing.
Yes, please go ahead, Fatima.
Yeah, so Health Canada, when the Health Canada is a body that on top approves all these medical devices and testing agents. The rationale behind the committee that does the review is they want to put devices out there that are accessible to all. So the guideline that comes from up top for all the provinces is to open it up and have anybody to train as many people as possible to be able to use this and be massively deployed. The advisory, the National Committee on Testing, actually, that's the recommendation that they've put out, that the testing should be accessible for everybody to do.
Okay, thank you. So it looks like everybody's able to unmute themselves now. So please, if you do have a question, you can go down to the bottom of your screen and click unmute. And we'll give everybody a few seconds here to see if there's anybody that would like to.
So from Michelle too, she's an occupational health nurse with OCAL. She said, thank you very much to Leon, Dr. Genesov. Great information. Do you have an opinion on whether public health units should be obliged to report specific information about workplace outbreaks? Example, industry or name of workplace. Also, she says, example, some PHSUSs are choosing not to report location. Example, agriculture on the public health reporting sites.
It's not part of my discussion today, so I'm just not going to comment on that. Thank you.
Okay, thank you. Thank you, Dr. Genesov. A couple of more, Cheryl?
I do. I have two more. So Diane Togliski says, I would like to hear more about the phase 2, those who cannot work from home prioritization, in particular for construction or non-licensed home daycares.
For vaccination?
I believe so.
We're going to see in phase 2 the opening up to again, there's more detail in the province's post-provincial plan in terms of in phase 2 who it's going to open up to. So frontline workers and people that cannot work from home, and other folks that are in sort of high-risk settings. So that's all detailed out in the province's phase 2 plan. So if you go to the province's website on vaccination, and they have specific details on the plan.
Wonderful, thank you. We can add those links as well into the chat for you if you like. So from Melva, the last question I have here in the chat says, can someone comment about blood donations and if they change one's COVID antibody levels after infection or vaccination?
Dr. Adarkwa, do you want to try and take that one on?
Repeat the question specifically.
Blood donations and if they change one's COVID antibody levels. So I'm assuming that means receiving blood donations after infection or vaccination.
If I understand, I'm going to try to rephrase it. If I'm understanding, the question is, if you get vaccinated, can you give blood? Is that what the?
Yeah, yes, I have patients asking the question if they can donate blood. They're afraid it's going to reduce their antibody levels, and I don't think that's the case.
No, I don't think it's an issue at all, actually.
Yeah.
I don't think it would. I mean, all blood gets, the same rigorous testing, and if there are specific antibodies that they need to test for, they'll test even before they give to patients. But I don't think it's an issue that will prevent you from donating blood.
And is there a wait time? Do you know? I can call and find out for myself, but I was wondering if anybody knows if they want you to wait after your vaccination before donating.
I haven't heard anything along those lines. I mean, in terms of just knowing when you'll develop antibodies after being vaccinated, I believe within a few weeks you should be have antibodies. But in terms of that preventing you from donating blood, I don't think it's an issue with donating blood at all.
I want to echo what Dr. Akarwan said. There is the way that the body generates immunity. It's nothing to do with your blood volume. So when you give blood, it's not going to impact how much titers you're going to be producing on an ongoing basis. I also highly recommend if anybody is interested to do blood donation, to go ahead and do them. I haven't found any advisories as of yet as to the period. Scientifically thinking about it, I don't see a reason for people to have to wait for blood donation. And just thinking about it theoretically, another thing I would like to add is we have an immunity task force. One of the mandates of the immunity task force is through blood banks, we're monitoring the level of immunity that's building up. So by donating blood, not only you're helping save a life, you're also donating a data point to our national, sort of how nationally we are doing in terms of immunity.
Thank you very much, both Fatima and Dr. Adarkwa. That's great, and that was a great question. Thank you to the person who had asked that. Cheryl, you have some more. Go ahead.
I just have one more here. It's from Kevin Hedges, our occupational hygienist. There is a practice for HCW healthcare workers is to wear surgical masks instead of N95s or better in COVID wards. Healthcare workers doing AGMPs. This practice does not follow the requirements outlined in the CAN CSA, which puts care workers at increased risk. Would you care to comment?
Who would like to tackle that one? Go ahead. Yep.
I mean, if I understand, I think that the question is, are certain people not required to use surgical masks when they're around COVID patients? Is that the question? And is that okay?
Can I chime in and just provide some context? So my partner loves Grey's Anatomy. It's a show from the US, and you'll see healthcare workers in powered air purifying respirators, in COVID wards. So, and just to sort of set the scene here, I'm an occupational hygienist. I'm certified. I've been an occupational hygienist for 31 years. And now that the CDC, talk about, aerosol exposure being the predominant route of exposure, and also Theresa Tam coming out in Canada here, about aerosol transmission and the importance of it. We're seeing healthcare workers in surgical masks in COVID wards that aren't doing AGMPs. And in our webinar last week, we had Lisa Brossu talking about surgical masks as source control. What she was implying that, they may not even provide good source control. So, there's high levels of infection out there for healthcare workers in care settings in long-term care homes, and these healthcare workers still the normal procedure is to wear surgical masks. I just wondered if anybody had anything to add to that. Any comments there?
I would not argue, but I actually agree. I think if you are if you're seeing COVID patients, actually in this day and age, you don't know. Because if I go see a patient, for example, if I go see a patient in the emergency room and they have, usually when I see them, they're either in shock or some level of respiratory issue. I'm always under the assumption that it could be COVID, right? And so I'm always wearing a form of facial protection, whether it's an N95 or just even a regular surgical mask. Even in our hospital, even people who are not taking care of patients directly are still in some level of protection, whether it's surgical mask or an N95. And I think it's I think it's something that it should be a practice that should be continuously practiced or done until we learn a little bit more about the disease. Right now, like I said, all of our patients, whenever we go into a COVID room or even we're dealing with COVID patients, or even patients that we're suspecting that could have COVID, or we still wear some level of protection, whether it's an N95 or even a general surgical mask.
Thanks, Dr. Doug. But my point of clarification here is that a surgical mask is a barrier, to prevent an outward leak or to stop anything coming out of the mouth and nose. A respirator is actually personal protective equipment that's approved, tested by NIOSH. So they're different. They're totally different. I just wanted to make that clear. Thank you. I don't know if Leon had a comment there at all. If he'd be prepared to. Okay, thanks.
All right. Thank you, Kevin. And Cheryl, you have a few more questions? We probably have time for maybe 2 or 3 more.
Oh, sorry, that was it for everybody that I have. Thank you.
Okay.
I have one question, Patricia, in the Q&A.
Yep. Great, Jen. Thank you.
Able to export. Okay. So the question says, various epidemiological reports, WHO Canada government, reported a 6-week-long deceleration curve beginning around the beginning of the new year. That deceleration has ended and we see an up curve again. Can presenters outline the possible explanation for the sudden declines and consequent upticks? At what point of the vaccination campaigns nationally and internationally can we expect a demonstrable effect on new cases?
That was a really long question as well. Does somebody want to take that one?
The only thing I can add is, again, looking at the success of vaccination in other jurisdictions like the UK with AstraZeneca and in Israel with the MRNA vaccines, Pfizer, that they're using there. So hopefully as the vaccination campaign rolls out, we'll also see a decrease in cases, a decrease in hospitalization, a decrease in deaths with vaccination. And again, those are good reasons to urge everybody to get vaccinated when it is their turn in the phases in Ontario. So I'd like to encourage everybody to go out and get vaccinated, again, with the proper information to make an informed decision.
Thank you very much, Dr. Genesov. Absolutely, like you say, be informed and get vaccinated. That's what's going to help us get to, I think, Fatima, you were saying, I think it was you, back to our kind of normal. So, okay, another question we have is, and I think this one maybe Fatima, will we need to get the COVID-19 shot every year, like we do with the flu shot? And are they going to be making like new, like different vaccines every year, like they do with the flu shot that we have to get?
That's a very good question. So we now know enough to say that this is a virus that is going to be with us. It's going to become what we call endemic, sort of like flu. Now, the thing is that genetically speaking, the genome of coronaviruses are different than flu viruses. They evolve differently, they accumulate mutation differently. We've seen the virus being transmitted, for instance, in minks in Denmark. I'm sure you've all heard the stories. It transmitted to mink and then from mink back to human. And it hasn't picked up any changes in its genome. If it was a flu virus, it would have become a totally different strain, which would have been a nightmare. So because of those changes, it's not really the changes in its genome and the evolutionary pressures that it's under. It's not 100% comparable to, let's say, flu vaccine that is required annually. The flu has so many different ways of evolving and changing. I imagine, especially because currently we have well-established variants within the population, we have community transmission of the variants, especially the B117, that as the other variants that that the vaccines against which are a little less efficacious, that we might introduce a booster that particularly address certain variants. How soon those boosters will be required, those are questions that are actively being pursued right now. Whether this is going to be a yearly thing, 2 years, every 2 years, every 3 years. Again, those are questions we don't have answers for just yet, but they are definitely being pursued and explored by multiple teams here in Canada and also internationally.
Thank you very much. We know, and even in our discussions today, you know, with it being so new, everything is new, and we're still really learning and it's changing, as Dr. Jenosev said, every day. So thank you very much, and that's great to hear that we are, you know, investigating and looking towards those things. So that's great. I have another one here. This one might be for Dr. Jenosev. The question is, I've had my vaccine. Do I need to keep following public health guidelines? My family doesn't have it. Can I visit them?
They keep following public health guidelines to the letter. It's very important. So first of all, you need 2 doses of the vaccine. The maximum effect doesn't start until 2 weeks after the second dose. I think as Fatima outlined, there's a lot of information we don't know. We have variants to consider, and the impact of the vaccines on the variants. How long does the immunity last? We don't know about. How long, as Fatima said, boosters, when do we need those, right? There's a lot of things we don't know. So we know the vaccines prevent disease, hospitalization. We don't have 100% knowledge about preventing infection and transmission, right? So it's really important to continue all the health protection measures and public health measures and workplace protection measures until we get more information.
Fantastic, thank you. Okay, so I think that's it for the questions. Jen, did anything else come in while we were answering those ones?
Yes, I just had one come in right now.
Great.
So this one says, some people are concerned about both COVID and the vaccines causing some issues with platelets and clotting. If someone has had a history of clotting issues, what advice would you give them?
Anyone want to take that one on?
Talk to their personal physician. Talk to your personal physician. Make an informed decision. You have to talk to your personal physician and make a personal decision about that with the proper information with your decision. Patricia.
Thank you very much. It is 3 o'clock. So thank you very much for coming today, Dr. Jenosev. It was fantastic. Appreciate it.
Thank you. Take care, everybody.
Thank you.
Stay healthy.
Thank you. All right. So I know in the interest of the speaker's time too, we can, if there are any other additional questions, please do put them in the chat and we can take a look at maybe sending them along and seeing if we can get some written answers that we can post online as well. But I think we've got all the questions at this point. So again, thank you very much to our speakers, Fatima, Dr. Adarkwa, very much appreciate your time, and Dr. Jenosev as well. So before we go though, I also want to say thank you to everybody for coming today, and please do join us at our COVID sessions next week, titled Elastomeric Respirators Beyond the Mask. We're going to be continuing from our March 5th session, face coverings and respirators, filling the gap. And this sequel delves into the guidance on elastomeric respirators and the programs in greater detail with several speakers. So please take a look at our website. You'll find some more information there and the ability to register for the events. And we also have another one coming up April 9th, which you'll see on our website as well. So thanks everybody for attending. Please do fill out our feedback form. It's very helpful for us moving forward on continuing with our webinars. And that's it for today. Have a wonderful weekend, everybody. Get vaccinated. All right. Take care. Thank you, everybody.